Good afternoon. My name is Kate Stanton, and I serve at the University of Oklahoma Health Sciences Center, the Associate Vice President for Student Affairs with responsibility in Tulsa and Oklahoma City and our remote sites. Welcome, everyone, to our educational webinar. We'll go over a couple of housekeeping items before I turn it over to our panelists. First, if you have a question for a panelist, please drop that in the Q&A button at the bottom of your screen. Again, if you have a question at any time during the webinar, please drop your question in the Q&A and we will cover those questions at the conclusion of the webinar. Also, before we get started, I wanted to read and give a couple of thoughts as we start this conversation about monkeypox. In talking to our Gender Equality Center and our campus health centers, I want to remind everyone that monkeypox does not discriminate. It is not a gay problem. Its presence within our various communities indicates we must talk, educate, and show care. Similar to other diseases, a disease initially presents in one community and moves into other communities in time. We are hopeful to offer information today to protect and show care for all. All right, let's move to our first panelist, Dr. Doug Drevitz, Regents Professor and Chief of Infectious Diseases. Dr. Drevitz.
Thank you very much, Kate. And I want to thank the organizers of this webinar for asking me to speak. And these are the questions that I'll be addressing today. First of all, what is monkeypox? And secondly, how to mitigate your risk against monkeypox as an adult. And to start with, what is monkeypox? Well, if you look over to the right side of the screen, there are a couple of electron micrographs. So these are photographs of what the virus actually looks like. And you can see that the monkeypox virus is on the lower side and has this characteristic blocky shape of a pox virus. Next slide, please. So when you think about it microbiologically, it's called an orthopox. And what that is, that's a large family of different viruses. So they're large double-stranded DNA viruses, and they like to replicate or grow inside of your cells. They're found in mammals, and believe it or not, almost every mammal has its own pox virus, and you can see that over to the right side of the screen in the light blue, where you have skunk pox, camel pox, cow pox, raccoon pox, vole pox. It's, there are just a lot of these viruses. Variola virus, which is again one of the orthopox viruses, is the causative agent of the disease we know or used to know as smallpox. Cowpox was the original smallpox vaccine used by Edward Jenner about 250 years ago. And vaccinia virus is the current smallpox vaccine. So these are all related viruses, and monkeypox is one of these orthopox viruses. Next slide, please. So the first thing you need to know about monkeypox is it's not specific to monkeys. And in fact, it typically lives in many other animals other than monkeys. And these are lists of different kinds of animals that monkeypox can live in. As you can see, there are non-human primates, there are rodents, possums, squirrels, hedgehogs, even prairie dogs and domestic pigs can harbor monkeypox. So monkeypox is just a bit of a historical name. Next slide, please. So a brief history of monkeypox is listed here. And it was back in 1958 when it was first identified in 2 colonies of laboratory monkeys that had a pox-like illness, and hence its name of monkeypox. So it's just kind of a quirk of where it was found that it got its name. The first human monkeypox infection wasn't identified until 1970 in the country of the DRC, Democratic Republic of Congo, formerly known as Zaire. And then for the next 40 or 50 years, there was sporadic disease and epidemics in Central and West Africa. The majority of these diseases, the cases were found in children, and they had case fatality rates anywhere to 1 to 17%. And it was considered a zoonotic infection, and a zoonotic infection is a naturally occurring disease in animals that sometimes spills over into humans. And this is what it was, and it was thought that it was mainly acquired from rodents or non-human primates. There are two different flavors or clades of monkeypox. One is called Congo Basin clade, the other one West African clade. And then in 2003, there were 71 cases in the United States, also linked to rodents, but these were rodents imported from Ghana. They were sick. They were co-housed with prairie dogs at a central facility, and the prairie dogs got infected. And then as these prairie dogs were sent around the country to be pets, people and veterinarians got infected from them. And then most recently, it was in 2017, that Nigeria had a reemergent outbreak with over 100 cases with different kinds of features. And I say it was reemergent because Nigeria had not had a case for more than 30 years or 40 years when this happened. So it was distinctly unusual. Next slide, please. And so this is the way monkeypox infection had been between 1970 and 2018. It was largely in Central Africa, and over those nearly 50 years, there were about 24,000 cases in the DRC, which had the bulk of the cases. And you can see the numbers of cases in other smaller countries. And you can see that for quite a few years, there's between 500 and 2,000 cases a year, but that over the last 20 years, cases were slowly creeping up and were increasing. Next slide, please. These are some historical features of the early monkeypox outbreaks or epidemics, you might say. And these are 5 different series or epidemics starting in 1970 and coming up through the 2017 Nigerian outbreak. And the first thing I want you to look at is the median age range of folks. And you can see that for the first 3 or 4 epidemics, these are primarily young children getting it. So half of the people in the first one were 4 years old or younger. In the second outbreak in the DRC, half of them were 5 years and younger, and same with 10 years and younger. So it's interesting that over time, the age gradually became older. And when you also look at the male-female ratio, typically it was fairly close to 1-to-1 with a little bit of a male predominance for the first 3 or 4 epidemics over the first 50 years. And this is thought that just that boys and men were more likely to be out getting exposed to this out in the wild than would potentially bring it home. And then there was transmission within the home. And then it was up at the Nigerian outbreak in 2017, where the male-female ratio changed, where it was more male predominant by over 2-to-1. You can also see the case fatality rates there. And again, most of the fatalities were in young people, pregnant women, and then later on in people who were co-infected with HIV and had advanced AIDS. Next slide, please. And it was in 2018 that something kind of a seminal event happened. There was what was called exportation of monkeypox from Nigeria. And these are several different cases around the world. 3 of them were found in the UK, 1 in Israel, 1 in Singapore. And then there was also an unusual one in a different state, an occupationally acquired one in Belize State in Nigeria. And this was thought to be kind of a key element of when the modern monkeypox virus spread to the rest of the world out of Nigeria. Next slide, please. The next key thing that happened was this year, and it started more or less like this. On May 7th, the UK reported a case in a traveler from Nigeria. So there's really not much unusual about that, because this is how monkeypox had been identified in many countries. But then the next week, there were 6 cases reported in London in gay or bisexual men who identified as having sex with other men. Right after that, 7 suspected cases in an STD clinic in Madrid. Immediately after that, 14 cases of monkeypox also in men. And you can see on the graph over to the right that during this time, there were major parties going on, particularly in the Canary Islands, also in Madrid, Berlin, and Antwerp. And many of these early cases were either there or had direct connections to people who were there. And then you can see how the virus, the cases have taken off since then. And those are just representative countries on 3 different continents. And then it was in July, the WHO declared a public health emergency of international concern to focus attention on this disease. And then a couple of weeks later, the US HHS, Health and Human Services, declared a health emergency. Next slide, please. So what's going on right now? There are just over 41,000 cases globally reported to the WHO this morning. And when you look over on the right, you'll see the demographics of cases that there are data there, and these are all data reported to the WHO, that over 98% are male, 97% identified as having men who have sex with other men, 91% of cases where there was an epidemiologic investigation identified some kind of a sexual encounter, and the most common exposure was a party setting with sexual context. And if you look at the chart or the graph on the right, you will see men are listed on the left side in the purple, females, women on the right side in orange. You can see it's predominantly, again, very lopsided in men compared to women, and that the median age is 36 years old. The timeline of what's going on is that people typically become sick about 1 to 3 weeks after they are exposed to it. And data from the Centers for Disease Control suggests it's about a week from your exposure to when you start having symptoms, and then one more day, so about 8 days, 8.5, 9 days, when you start developing a rash, and the rash lasts about 2 to 4 weeks. Next slide, please. So these are some pictures of what monkeypox lesions or skin rashes look like. These are from a patient taken who was in Israel at the time. And you can see that they're over the face, the back, the chest, and how they kind of have this particular looking experience. If you were to feel these, they would feel somewhat solid. And this gentleman's timeline is down there in the lower right. He was exposed to rodents about 12 days before his first sore, and then he had fatigue. A couple of days later, he started developing the rash all over his body. His fever finally went away, scabbed, and then about 2 weeks later, the scabs fell off and there were small discolorations and some scars left. Next slide, please. So what's happening now? The clinical features are that most people have these skin lesions or rash, and they progress more or less uniformly as a little papule, which means something that you can feel with your finger, to a vesicle, which is like a blister, to a pustule, which is like a blister with pus in it, but yet it's somewhat firm. It's not real squishy. And then it scabs and there's a scar. Realize that these sores are highly infectious, and this is how it is spread. Although you can also spread it, it's also, people have sores in their mouth. You can have it up in the saliva and oral secretions. In patients who are in the hospital, you can find it in blood, urine, stool, as well as semen. So these lesions are infectious. But what's interesting about the current outbreak is 85% of folks with this disease had less than 20 sores all over their whole body. So it's not likely that you're going to see lots and lots of these skin lesions as in the pictures. A relatively small number of people, a minority of individuals, are admitted to hospital, and that tends to be because of pain control. Sometimes these sores, they get infected with staph. Sometimes if you have it in your throat, you can have such severe throat pain that you can't eat or drink and you have to be admitted for intravenous fluids. You can also have sores on the eyes. And very few deaths have been reported. There's only been 12 deaths out of nearly 40,000 cases. Next slide, please. So how to prevent transmission about this? So just remember that if there are skin sores, skin lesions, they have to be covered until they're completely healed and the scabs fall off. Remember that you can shed it. People can shed it up in their lesions, up in their mouth if they have sores up in their mouth, and perhaps even if they don't. So sharing drinks with somebody is a potential route of having infection. It can also be up in the airways, and so there's a small chance that it can be spread through aerosols also. Fomites or inanimate objects such as doors, blankets, sharing things such as toothbrushes. Some of those, such as toothbrushes, is not a good idea and could lead to infection. Doorknobs, less likely, but just be aware that that can happen. And as I mentioned earlier, virus can be detected in many different bodily specimens. There are two different kinds of vaccinations. The one that is available is the Jynneos one, and it's thought to be about 85% effective. And folks of my age have had a smallpox vaccine when we were very little. That might provide some protection, but probably not as much as a recent vaccination. Next slide, please. So how do you mitigate your risk as an adult? Well, think about it. You got to limit your risk and limit your exposure to high risk settings. This is, in a sense, common sense. In terms of sexual prevention, this is not going to be a disease that is typically, or I should say, not going to be easily preventable by condoms, because it all depends on where the sores are. If you've been exposed, or if you think you're going to be exposed, and this could be because of occupational exposure, say you work in a laboratory or you give vaccine to people, or if you're at high risk due to sexual activity, there is a vaccine available, and this is available through the state health department and through this city county health department and other places. And it is a safe vaccine. It's 2 doses, 28 days apart, and you're considered fully immunized 14 days after the second dose. You can also do post-exposure prophylaxis. Let's say you're inadvertently exposed to somebody and they call you up and say, oh, I was just diagnosed with monkeypox. You can get a vaccine after that before you have the disease, and that can also help mitigate your risk. Next slide, please. Thank you for your attention.
Thank you so much, Dr. Drevitz. Next, let's talk about our children and mitigating risks for those folks with monkeypox. I'm going to turn it over to Dr. Andrew, who's our Chief of Pediatrics Infectious Disease.
Hi, thank you so much for inviting me to talk today. You can go ahead to the first slide. So as Dr. Drevitz discussed, historically, in endemic countries, children have actually always been the majority of the cases of monkeypox. So 2022 is a bit different. In 2022 so far, actually these numbers have changed a little bit. So the WHO has actually reported over 80 cases in children worldwide now. And this morning, there have been 11 pediatric cases of monkeypox confirmed in the United States. So most recently, there was an Illinois daycare worker confirmed to have monkeypox. So there was a bit of a scare at that daycare. So far, contact tracing has not seen any transmission to those children. And then over the weekend, we had the first minor infected in New York City. And so currently, we're unaware of exactly how many children have been exposed to the virus. Next slide, please. But the key points when we're talking about monkeypox in children is that this virus is not just an STD. Currently, it does appear to be, the majority of the cases appear to be in men who have sex with men. But just like with HIV, if the virus continues to spread and propagate in the community, it will spread to other members of the community. Most children will actually be exposed through caregivers or family members. And so far, that's how most of these children have been exposed. It's usually through close personal contact or via fomite spread. We know that monkeypox is more severe in children under 8 years of age, or anyone with eczema or any dermatitis or skin lesions that could result in more severe infection, or any children with immunocompromising illnesses. Then signs and symptoms of infection in children are very similar to what we see in adults, and there are treatments and vaccinations available for children at high risk. Next slide, please. I will just touch on fomite spread. So pox viruses, they can survive on linens and clothing and on surfaces, particularly in dark, cool, and low humidity environments. This is considered an unlikely but possible mode of transmission. So it's good to understand more about that. In one study, investigators found live virus in a patient's home on surfaces 15 days after the patient had been infected and the home was left unoccupied. So bedding and clothing tend to harbor live virus for longer periods of time than metal, glass, and plastic or more non-porous surfaces. The good news is that orthopox viruses are very sensitive to UV light and most of the disinfectants that we use and know very well for COVID-19. And then finally, the last slide. So it talks about the practical tips that we can use to actually mitigate the risk in children. One of them for people in college would be to consider going to parties fully clothed. That can help prevent the prolonged skin-to-skin contact, and then subsequently using the hand sanitizers and things that we know that can kill viruses on surfaces. And then finally, just paying attention to what's going on. I think in college, you can get moving in life and not really care or want to pay attention. But if you can once a week or once a month even look and see what's happening with the CDC, what's happening with COVID-19, what's happening with monkeypox, what's happening with polio virus, the entire community would be grateful to you. And that's it.
Thank you so much. Helpful information. Let's move on to an epidemiological update by Dr. Erin Wigglebow, who's a professor of epidemiology in the Hudson College of Public Health.
Thank you so much, Ms. Stanton, and also thank you, Drs. Drevitz and Tiangu. Just wanted to begin by adding a couple additional points that I believe Drs. Drevitz and Tiangu already mentioned, is that right now we recognize that there is a lot of fatigue just when you hear the words epidemic or disease or spread or prevention. We've lived through COVID and we kind of want to go back to living our lives as normal. There's terms like revenge travel, and I don't have a lot of data, but I suspect that some of the reason why monkeypox is being spread the way it is because people aren't paying as much attention to disease prevention as we could coming off the heels of this COVID pandemic. And so I really do appreciate all of your attention and wanting to get more information about monkeypox. So this has become a public health emergency of international concern. The World Health Organization made that declaration last month, July 23rd, so almost exactly 1 month ago from today. And as of now, as you've already heard, there's over 41,000 cases worldwide in 88 non-endemic countries, and at least 3 deaths have been reported in non-endemic countries. There is some variability on the reporting sources depending on where you get your data from, and so if you see different data, that's somewhat to be expected. And then the US declared monkeypox a public health emergency on August 4th. Next slide, please. You saw this graph earlier, just wanted to briefly share it again. You can see that we've seen a pretty steady increase, but now there is at least some hope on the horizon that the increase doesn't seem to be as steep, but we are not declaring victory by any stretch of the imagination yet. We still really need to be very vigilant about disease spread, and it's going to differ by country. Next slide, please. These are those countries that have been affected. The yellow dots are what are called the non-endemic countries, whereas the blue ones are endemic, as you had seen previously from Dr. Drevitz's presentation. Next slide, please. And so here are 2 different graphs indicating the numbers of monkeypox cases by country. So on the left, it's actual numbers of cases, and then on the right, it's rates, so numbers of cases per population. And you can see that the United States has the most numbers of cases, and some of those countries that had some of the earliest spread, like Spain, seems to have maybe plateaued. Again, we hope so. The situation in the United States is a little less clear. And, when we look at both of these graphs, I think we just see that this is a worldwide country. Certainly the United States is being affected, no matter how you look at it, with numbers of cases or rates. And so something we just need to continue to pay attention to. Next slide, please. And you've also seen this graph. This is the cases in the United States. There's been at least 15,433 reported in the United States. Again, I think that I'm grateful that the steep increase hasn't continued over the past couple weeks, but again, we need to see how this plays out in the near future. Next slide, please. And here is the map of those states being affected here in the United States. And so there's been at least 20 cases reported in Oklahoma. Next slide, please. And then these are the numbers of cases being reported in our region. So clearly, Texas to the south has reported many more cases than we have reported, but this is something that, you know, we just will continue to monitor. We'll do case investigations and hopefully be able to notify people if they have been exposed, so that everyone can take those prevention measures. Next slide, please. And fortunately, the CDC is reporting that nobody has died in the United States. Again, I've actually seen some different reports from different sources, but since I was using CDC's data for all of these data, I just tried to stick to one source for now. Next slide, please. And then this is just to see some of the distribution by race and ethnicity, and how you know, different populations do get affected over time. There in May, it was largely confined to the white and Black or African American populations, and over time it's certainly spread to other races and ethnicities. And one thing to keep in mind is that these are, again, percentages, so it doesn't control for the size of the population. So just knowing that we don't have as many, say, Black or African American people or Hispanic people living in the United States is compared to white, that then they are disproportionately affected as of, you know, August 14th. So again, I think we need to be thinking about how do we provide reliable information to all communities so that everyone has the information to prevent disease spread. And with that, I would like to turn it back over to you, Ms. Stan.
Thank you so much, Dr. Wigglebow. So what to do with symptoms if you are having any symptoms? So let's turn it over to Dr. Dale Bratzler, who's our interim dean for the Hudson College of Public Health. Dr. Bratzler?
Yeah, thank you, Kate. Really a pleasure to be here today. So let me just make this all a bit more confusing. So what are you going to do if you think you've potentially been exposed to someone with monkeypox or have some symptoms of concern? And let's just talk about what are those symptoms that often happen in people who get infected with this particular virus. So next slide. So on the left, I've listed the symptoms of monkeypox. Fever, chills, swollen lymph nodes, exhaustion, muscle aches, backache, headache, and respiratory symptoms like sore throat, nasal congestion, or cough. Now, that sounds like a whole lot of other diseases that we've been dealing with. Sounds like it could be very similar to COVID. It could be influenza. There are lots of diseases this time of year that have these non-specific symptoms of fever, chills, exhaustion, muscle aches, and headaches. And then just to make it more complicated, some people will present with those flu-like symptoms first before any rash develops. Some people will get the rash first, and then it will be followed by other symptoms. And then some people, a small percentage, only experience a rash. So how do you decide what you need to do? So on the next slide. So first, it's really important that you understand the diagnosis can only be made by a healthcare provider or a public health professional that's actually doing laboratory testing. Sure, if you have a full-blown case of monkeypox, most people are going to recognize what it is, even though you still have to do testing to confirm the diagnosis. The second point I want to make is the majority of people with this illness actually don't need to be in a hospital. As Dr. Drevitz pointed out, less than 15% of the people ever need to be in a hospital. And quite honestly, for most people, we don't need to do any particular treatment. So that means the patients go home and they isolate. And here, strict isolation is important. I know in our conversations at the university, we've highlighted that isolation for these patients may last anywhere from 2 to 4 weeks because you have to be considered infectious until the rash is completely resolved. So our general recommendation at this point is if you think you've been exposed or you have some symptoms that you think, could be consistent with monkeypox, particularly if you've been in some circumstance that would put you at greater risk of the disease, first call your respective campus health center to get instructions on what to do. Because when you call the campus health center, they may instruct or for you, go ahead and contact the health department to arrange an evaluation to decide whether or not you should be tested. Really, testing requires primarily finding the rash and getting a sample of the rash. So they may actually recommend that you don't come to the health center first until they've had a discussion with the health department. Our university health providers will coordinate with either state or county health departments for both testing and then, very importantly, for vaccination if somebody has been a direct contact. So let's say you're a direct contact, but haven't had any symptoms at this point, then in that particular circumstance, we would recommend that you be vaccinated to prevent the disease from occurring in the first place. Next slide. So just to remind everyone, on the Norman campus, the main line is 405-325-4611. Goddard is open 8 a.m. to 5 p.m. Monday through Friday, and that's where you would call. If you do go in to seek treatment, remember there is a small chance, as Dr. Drevitz pointed out, that some people, if they're infected in the airway, could spread this disease via aerosols. So if you go into one of the health centers, please wear a mask. And just remember that this disease primarily spreads by direct contact, being in the face of a person, skin-to-skin contact. On the Norman campus after hours, you can call either Norman Regional Hospital or Norman Healthplex, and those numbers are actually on the Goddard website if you need to look those up. On the Tulsa campus, the OUTU School of Community Medicine Student Services clinic is open from 8 a.m. to 5 p.m. Monday through Thursday and 8 a.m. to 4 p.m. on Friday, and call the main office number, which is 918-660-3500, or here's the email address for the Tulsa Community Medicine Student Services Center. So again, call first and they will instruct you. They may actually talk to the health department before they would ask you to even think about coming in. And then on the Health Sciences Center campus, the Student Health Clinic is open Monday through Friday, 8 a.m. to 4:30 p.m. The phone number is 271-9675, or after hours, we actually do have an emergency care number, the OU Health Emergency Department, where you can call. Again, we're strongly encouraging people to call first if you think you may have been exposed, so we can talk to the health department and determine the best course of the evaluation for you. Remember that this disease is a bit different from COVID-19. COVID-19, once you're exposed, there's no way to prevent the disease if you're going to get the infection. With this particular disease, if you are you've had direct contact with somebody with monkeypox, get vaccinated as quickly as possible, because it may prevent you from getting the disease altogether or may dramatically reduce the severity of illness if you happen to go ahead and get infected. So again, following up quickly is very, very important. Next slide, I think that's it.
Thank you so much, Dr. Bratzler. Well, now we're going to open it up to some questions after your thoughtful educational slides. First question we've received is, how worried should we be about monkeypox? I heard that we're in a public health emergency, but I haven't heard about anyone I know being diagnosed. Dr. Drevitz?
Well, I don't think you should ever worry. This is a great question, by the way. I don't think you should ever worry. I think you just need to be aware of what's going on. And as Dr. Wigglebow pointed out, there's only been, I think, 20 cases in the state of Oklahoma. So it's unlikely that if you've just been here, you would know about somebody. Other states have had a lot more. So the notion of a public health emergency is mainly to focus attention and some government resources, but it is not a call to quarantine, to mask, to socially distance, to do things of that nature. Again, so this is part of it, where it's a call to publicity, in a sense, to publicize what's going on so we can educate folks. So worried, no. Thinking about it, sure.
Thank you so much. Another question is regarding the efficacy of the full dose recommendation versus the based upon 0.1 milliliters of the dosing. Dr. Drevitz or Bratzler, can you speak to that question?
Sure, I'll start and then I'll let Dale give you the right answer. So the idea of giving it intradermally instead of subcutaneously comes from, basically has two notions. One is you can, as you point out, you can give 1/5 of the dose. It, in theory, is the same efficacy, and there is, I should say, there are animal data and some human data looking at antibody titers after subcutaneous versus intradermal dosing. And this kind of a switch has been known and is done often for other kinds of vaccines. And it works because you recruit in different kinds of immune cells when you give intradermal. It's a more effective boost to your immune system. The real difference gets to be you tend to have more side effects with it intradermally. And so there aren't as many safety data out there. And of course, then there are the logistical things about how many times you can go into the same bottle, what kind of a needle, how deep. It's technically more difficult to give it. But in theory, it should be 85% effective. You can have more reactivity though. So more local reactions and probably a few more systemic reactions.
Dr. Bratzler, if you could unmute, thank you.
The only other thing I would point out, Kate, is that this intradermal approach to vaccines has been tried for a number of vaccines, and similar findings that they tend to be very reactogenic when you give them directly into the skin.
Thank you so much. Another question, do health experts believe that monkeypox will remain in the community like COVID has persisted for the past years? Dr. Wigglebow?
Sure. Thank you. This is part of a follow-up to the first question about being a public health emergency, and I would just add that I believe that public health experts wanted this to be a public health emergency so that we could get that information early on. We have the opportunity to prevent spread, and so I think that's the goal of public health, is to try and make it so that it does not persist in any community. And it'll take a partnership of everyone. So again, maybe there's some concern, but I think many of us are optimists that we'll be successful in preventing the spread.
Thank you.
I would just add a little bit on that one, Kate, that, you know, COVID-19 is so much more transmissible and it's also airborne. And so monkeypox is kind of person-to-person contact, close direct contact. So hopefully it's something we might get our arms wrapped around. No pun intended.
Thank you, Dr. Dr. Bratzler, what is the risk of going to the gym and what steps can be taken to mitigate risk in this setting?
Yeah, I think it's an important question, and one that we've had in numerous conversations with the university, with their various sites, particularly with the health facilities, the gyms and others. And the big thing is, just like you would do for any disease that's spread by contact, which can include things like staph infections, please wipe down the equipment after you use the equipment or before you use the equipment. That's how we reduce any of these infectious diseases that are spread by direct contact with what are called fomites or hard surfaces. As Dr. Drevitz pointed out, a recent relatively small study that CDC reported this week showed that if you test surfaces in the home of a person who has monkeypox, you can find the DNA from the virus all over the place. It's there. Whether or not you can get infected or not is not absolutely clear at this point. So just, I think as a matter of routine, when you go to a gym, be sure you're wiping down the equipment, which may prevent staph and monkeypox and anything else that could be in that setting.
Thank you so much, Dr. Bratzler. Dr. Wigglebow, do we know the R0 of the monkeypox? Is there a chance it could go up like COVID-19 over time?
The best estimate I have for the R0 of monkeypox is 1.25, and even that has been estimated differently depending on the outbreak. I do not know the R0 for monkeypox in the United States, so if one of the other panelists has that information, that would be fantastic. But it's unlikely that the R0 will increase to the same degree that COVID did, similar to what Dr. Tiangu mentioned, though I believe that this particular clade, this outbreak strain, does have a higher R0 than some of those previous clades that Dr. Drevitz was introducing at the beginning. And so I think we're seeing some evolution of this virus that's making it a little bit more infectious, but I don't think it's going to be on the order of COVID.
Thank you so much, Dr. Wigglebow. We have a question of why did the Oklahoma State Department of Health decline to receive Oklahoma's full share of available vaccine? And each of us represent the University of Oklahoma Health Sciences Center. I'll see if any of our panelists have any information, and if not, we'll just move on to the next question.
Next question.
Thank you so much. Should we be encouraging everyone to get the vaccine for monkeypox? Dr. Drevitz?
So I think everybody who is at high risk for it should look into the vaccine. And there are criteria, and it's generally behavioral in a sense, and then what kind of situations are folks going to be in. Also, if you happen to be, say, your partner or you're living with somebody who developed monkeypox, then that puts you at high risk. But the idea is that, yes, people who think that they may be at high risk can go to the state health department website or the city county health department website, read through the criteria and make a logical assessment if they're at high risk. And then there are vaccination sites cropping up in the community that you can access that. So I typically am in favor of vaccination. We are somewhat limited in terms of the numbers of vaccines available, but other places, I've talked to 2 folks who've gone out of state to get vaccinated, one to Illinois, one to California. So you might look into that option also if there isn't vaccine locally available.
Thank you, Dr. Drevitz. How should I schedule monkeypox, flu, and COVID mRNA booster if becomes available vaccines? Should I wait a couple of days in between? Dr. Bratzler?
Yeah, so generally we have lots of experience with combining vaccines like pneumonia vaccines and flu, and we typically recommend that people get them at the same time. And that's likely going to be the case with COVID-19, the recommendation that if you're getting your flu shot and you're due for a COVID booster, to get them both at the same time. So, and in fact, most of the vaccine sites that I'm familiar with are planning that this year to be able to deliver both COVID boosters and flu shots at the same time. So that's perfectly safe. Again, I would say the majority of people at this point don't need to get a monkeypox vaccine. Has been highlighted. There have only been 20 cases in the entire state. Obviously, the direct contacts are all going to be vaccinated. And the health department is going to do detailed contact tracing to try to make sure that any direct contact gets vaccinated. And as you heard, the criteria to get a dose of the vaccine from state and local health departments now has been expanded to include that group of people who are at greater risk of contracting the disease. And if you look at the CDC or the state health department's website, they spell out the people that are eligible to get the vaccine, but most aren't going to be eligible to get monkeypox at this point and probably don't need to.
Thank you so much. Besides washing hands, are there 3 things people should or shouldn't be doing in public, such as not trying on clothes or things along those lines? Dr. Bressler, you're unmuted.
I'll take a shot at it. So obviously, as I kind of pointed out with gym equipment, washing your hands is just good for your health. And it will prevent lots of other diseases that we deal with all the time. So remember, this disease, monkeypox, that we're talking about today is skin-to-skin contact. And again, your chance of running into somebody on the street that's actually infected is pretty low at this point. But you know, just doing good hand hygiene is important. I think the picture that maybe it was Dr. Wigglebow, I can't remember whether it was Erin's or Donna, the picture of a group of, you know, a large group of people dancing and getting together. Keep your clothes on. That's good because you don't know who else is in the crowd, and not having direct skin-to-skin contact is really important. I think the risk if you're going shopping to buy clothes is quite low at this point. So I wouldn't tell people that you can't try on clothes in a department store and things like that. But just knowing your surroundings, knowing, you know, the people that you live and work with and things like that. That's the things that are going to be most important.
So what I hear you saying is wash hands. We can continue shopping and use our brains. Got it. What about you,
And
Don?
don't share toothbrushes.
Don't share toothbrushes.
Yeah.
Don't
Got
share
it.
toothbrushes.
That's just a piece of lifetime advice from a bunch of physicians and student affairs. Let's move on to the next question. Has there been any communications or educational outreach to student populations? And thank you to all of our presenters. We have well, I would say that we started with today as one way for some education to our communities, and this webinar will be posted on our sites. But almost 3 weeks ago, different information was moved through our communities and different populations within the university system. We'll also have ongoing education, as we know this is a hectic time of year with onboarding and joining school. But we certainly want to remind folks where information is on the HSC Together, our OU Together pages. There's additional information there on monkeypox. But if anyone has a suggestion or a way to get out more information, please do not hesitate to email students, that's with an S, at ouhsc.edu, and we will work with our marketing and communications department to share that information. All right, a question. When we call in sick from work on campus, we need to wait for test results for COVID or monkeypox till we receive clearance to return on campus. That is true. On the pack about COVID, we still have our mandatory screening and reporting tool, and that is found on our web pages. Monkeypox, you heard Dr. Bressler go through the steps of that and how to contact the different health centers on campus, or perhaps your local emergency room if it's after hours. The contact, like in the event that any individual is ill outside of COVID, is conversation with your manager or supervisor to talk and discuss what that looks like for you to maintain your responsibilities. The person's question to our physicians talked about what is the time allowed to resume normal activities, particularly patient-facing activities. So Dr. Drevitz, do you want to share on that? Or Dr. Tyanju, do you want to share on that?
Tyanju would be great for this one.
You want me to share on this one?
You set the policy in the hospital, so you're good.
Oh, well, yeah, the policy in the hospital, you know. Anyway, if somebody is actively infected with monkeypox with active lesions, they need to not be patient facing or facing anyone else except for their home with family probably, until their lesions completely fall off and we have kind of new skin underneath, because you're typically very infectious until that point. Sometimes that can take 21 days or so.
And on that note, that would be consistent with anyone that's patient facing, correct? So any of our learners or any of our providers, correct?
Right.
Thank you so much. All right. Dr. Drevitz, can getting the vaccine cause any of the rashes? So the question being that, can the vaccine cause a reaction like the actual infection on the skin?
No, the answer is no. This vaccine, although it's a live vaccine, it doesn't replicate. And what that means, it's not going to keep dividing once it's in your body. So you make an immune response, and you can have, some kind of a rash to an immune response, but it's not going to be something that's going to look like monkeypox.
Thank you. Very helpful. Question. Finding a dermatological findings in skin of color can differ from those with a Fitzpatrick skin type 1 or 2. Is this the case with monkeypox? And if so, what findings should physicians look for? Dr. Drevitz or Dr. Bratzler, Dr. Andrew?
So I don't think there'll be a large degree of difference between skin types and skin colors in this. When it starts out as a papule, it's palpable, meaning that you can feel it with your finger. It's going to be a raised thing, and then it goes to the vesicular stage. So it's not going to be something like a measles or what we call a morbilliform rash, where it's a little harder to see. But I'd love to hear other people's comments.
I mean, just looking at the pictures, it's very similar, regardless of racial ethnicity, like the way the rash actually presents on everyone. Although it's important to say the rash can look very, very different from the different stages. So it might look like a little pimple and then become a papule later. But I think as far as the, racial ethnicity concern, it looks very similar on everyone.
Thank you so much. While we have you unmuted, can you speak to any differences on children that we need to be thoughtful of?
No, it's very similar to in the way it presents in children. Luckily, if we had the other clade spreading, the disease is actually much worse. Unluckily, the clade that we have spreading is kind of less severe, so it doesn't kind of present from like head to toe rash that you would if you look at kind of textbooks, you'll see that. So you can have people with just a rash like right here on their arm, or just a rash in one place or another. But children present very similar with prodromal illness followed by rash.
Thank you so much. Dr. Bratzler, anything else on that?
No, I don't think so. I think, Dr. Drevitz pointed out that a lot of the people with this particular disease don't look like the textbooks, as Donna said. They have few lesions, much fewer, but they're very characteristic.
Thank you. Another question. How effective is the post-prophylaxis exposure vaccine for preventing symptoms / complications for exposed patients? Dr. Drevitz?
I don't have great data on that, because I'm not sure there is great data, or there are great data. I would say it's going to be no more than 85% effective. That would be the ceiling that it would be. I would guess it would be less effective than that, though. It would also depend upon how extreme the exposure was, so high dose, low dose, and then how many days it's been between the exposure and the vaccination. So if one is exposed on Monday and gets vaccine on Tuesday, it's going to be much more effective than if one is exposed on Monday and waits until the following Monday to get vaccine, because they may start developing symptoms on Tuesday or Wednesday after the vaccine. And in that case, it may not be very effective at all.
Thank you, Dr. Drevitz. How do you distinguish a rash from shingles from monkeypox? Dr. Bratzler?
Yeah, so shingles is a disease caused by the chickenpox virus that has persisted in your body for a long time and infects what's called a dermatome. So a couple of things with shingles that are very characteristic. One, the lesions are smaller and they look like little, what we call vesicles, clear fluid in them that are raised. They will never cross the midline. So if you see a person, I say almost never, but if you see a person with shingles, it will usually be on the right side or the left side of the body, usually in a distinct patch, and it typically will not cross the midline because it's affecting a single nerve root where the virus becomes reactivated. Very different than monkeypox, which can occur in any part of the body. You could have multiple lesions. And as Dr. Drevitz pointed out, you can feel it as a papule first, and then it will get that kind of clear liquid in it, but then it will look more like a pustule and get kind of a cloudy fluid in it. So it will progress over time. It's the best ways I can describe it. Doug may have better other.
I have, I was fortunate enough in a sense to be able to care for somebody Friday and Saturday who actually came into the hospital with monkeypox virus. So I was able to see it, feel the lesions, talk to the gentleman. And it was interesting to me that they really did have a different feel to them than the cases of zoster that I'm used to seeing. The monkeypox virus lesions were much firmer. And he had a few at the papular stage. Most of them were pustular and a little bit umbilicated, but it was just very interesting when I would touch them. They just had a very different feel, more firmer, more solid. Whereas the ones that I'm used to with varicella zoster virus tend to be much, much thinner and fragile in a sense. And that being said, if you had somebody who is immunocompromised and had disseminated zoster, it could be difficult. And of course, the simple answer to that is you take a swab and you do a PCR and you look for zoster. Same thing with herpes simplex. You can have disseminated herpes simplex in some individuals, and in these kind of cases, it can be more difficult, particularly early on. And so you do have to rely on PCR and diagnostic testing. And you would hope that somebody with who's that sick and has disseminated disease of either herpes viruses or zoster would be in the hospital also, so you could have the laboratory backup.
Thank you, Dr. Drevitz. If your exposure is non-sexual, for example, on your hands, can you still develop rashes on your genitalias or in your groin area? Dr. Bratzler?
So this virus does get into the bloodstream. So yes, potentially you could have lesions anywhere with this particular virus.
Dawn, are you seeing the same for children?
Children are great little petri dishes, but if you have infectious virus that's spread through pustule, like once that lesion breaks, that virus can move around. So I don't know why you wouldn't expect it to also show up in other places.
Thank you. Dr. Wigglebow, has a model been built to predict a peak?
I believe they've been built, but I am not privy to the results, and I have not done any monkeypox modeling yet.
Thank you. a fabulous discussion and information shared, as well as a sense of community for all people. As we go into closing, I would love each panelist to be able to give one piece or one nugget of advice. As we have started the traditional semester, we know that the traditional flu season can be ahead of us, but also just general health. So you all come up with your one nugget. I also want to give special thanks to Darcy Choi, a project manager in student affairs, for making this happen today. All right, I'm going to go alphabetically. Dr. Bratzler.
Yeah, thanks. So one thing that we've highlighted before for multiple diseases, if you're sick, please don't come to campus and spread it around. If you're sick, stay home. You may or may not need to go get tested, but if you're sick, please stay home.
Thank you, Dr. Bratzler. Dr. Drevitz, what's your nugget?
Boy, this is hard. I would say you need to use a commonsensical approach to it, and don't put yourself in situations where you could be at high risk, and just be aware. But as Dr. Bratzler said about going to the gym, you're actually much more likely to get staph at the gym, and you're probably much more likely to get staph someplace else, or herpes viruses or things. And don't forget, monkeypox can look like herpes, can look like syphilis, and those are all things that need to get taken care of also.
Thank you, Dr. Drevitz. Dr. Tandrew?
Yeah, just have everybody remember it's a cool time to be in college, and you're living through a very historic moment as far as infectious disease is concerned. And if you love what you're living through, please consider a career in pediatric infectious diseases at the end of the day. Also, if you want some entertaining CDC advice, they have actually posted a safer sex and social gatherings monkeypox pamphlet that's incredibly entertaining about how to have sex without touching each other.
Always helpful. Dr. Wigglebow.
Eat breakfast, get plenty of sleep, just stay healthy throughout the semester. We care about all aspects of your health, including your mental health. And there is help available on our campuses with incredible healthcare physicians. And you've been able to hear from 3 of them, and really grateful to work with all of the panelists and to be serving you as a OU community.
Dr. Wigglebow, it's like we paid for your advertisement on behalf of all student affairs to say to take care of yourself. There are resources for our employees, of course, on all providers, and that education is the key to that. So take care, good night, and thank you, everybody.